webinar. Today, Raleigh Orthopaedic Sports Medicine surgeon Dr. Matthew Boes will be hosting a webinar discussing undergoing rotator cuff surgery and what to expect. Matthew Boes to begin the presentation.
Well, good morning or good afternoon. I'm glad people are tuning in here, either while we're doing the webinar or in the future, checking this out on the website. What I'm going to do today is talk a little bit more about the rotator cuff. We've talked in the past, give some background on why rotator cuff tears are important and what are the kind of implications of having a rotator cuff tear. We're going to talk a little bit more today about what's the nuts and bolts of getting a rotator cuff repair. What can you expect before, during, and after surgery? So we'll go through that a little bit of detail here. Okay. So we'll talk a little bit briefly about the anatomy and the pathology of rotator cuff tears, and then really, the rationale for surgery and the goals of surgical treatment, what we're trying to accomplish with rotator cuff surgery, some of the details of the procedure, and particularly the post-operative rehab, kind of results you can expect, some brief tips on how you can maximize your outcome when on this procedure. The rotator cuff is made up of 4 muscles and attached tendons. They all come off the shoulder blade here. You can see the front, the and the back. And they start off as muscles, and they come out to the side. They form these white tendons. These tendons kind of interdigitate. They interweave. This over here is looking from the side. And you can see they form this confluent 3-sided sleeve or curved tissue that attaches to the front, the top, and the outside part of the upper arm bone. And understanding the anatomy allows you to really understand what the function, the main function of the rotator cuff is, and that is to stabilize the shoulder joint. The shoulder joint's a ball and socket joint. You can see the ball shape at the top of the arm, and it fits and attaches to this little tiny socket on the outside part of the shoulder blade. And because of the size mismatch, the shoulder joint's a little bit inherently unstable. And what the rotator cuff does is in 3 planes, both top, the front, and then the back, it provides a force to hold that ball in the socket, and this function's critical. If we don't function, then we lose, as you see this, as this gentleman's overhead elevating his arm, we lose that normal kind of fixed fulcrum at the bone that allows the shoulder or our arm bone to rotate around and be elevated overhead by larger muscles around the shoulder. So the rotator cuff function is really critical. Well, how do we injure these? How do we injure this structure? Certainly, you can have a fall or an injury that causes a sudden tear. What we're finding now is that most of these injuries, most of the tears are due to just repetitive use and wear and tear over time. These tears tend to increase in incidence with age. We think it has to do with some intrinsic tendon generation in the blood supply that occurs with age. What we know is that this is kind of a spectrum of illness where there's anything ranging from initially a little bit of bursitis or irritation in the bursa that sits around the rotator cuff and tendinitis, and this can progress to some partial tearing, which ultimately progress to full thickness tearing. When we talk about rotator cuff problems, we're really talking about this kind of spectrum of disease. We're talking about someone who has a fall or dislocation and a sudden injury, and most people kind of develop this over time. What does this look like? This is impingement syndrome. This is looking at the front of the shoulder. There's a small slippery layer of tissue called the bursa that's above the rotator cuff tendons. And over time, this can get irritated. Oftentimes, people hear about bone spurs. This upper portion of the shoulder blade, which sits over the rotator cuff, can either have a sharp hook shape to it or can have some spurring over time that can wear down in the underlying bursa. The end of the collarbone that can develop some bone spurs. You can have some thickening in this ligament in the top of the shoulder, and all these can contribute to rubbing and irritation in the underlying cuff tendons and bursa. And what happens is this gets inflamed. It moves and slides freely up underneath this top bone, and pain and irritation when that tissue is compressed between the outer part of the arm bone and the upper part of the shoulder blade here, and that's the impingement syndrome. It's a little bit little bit confusing for patients to understand this, so let's go through this. Kind of cone in at the front attachment to the top part of the rotator cuff, and we look a little bit more closely, we see that normally the attachment of the rotator cuff is not paper thin, It's about 1.5 centimeters of thickness of the rotator cuff. And so what you can have is detachment of the rotator cuff or pull the tendon. I tend to tell people to think about this like a shoelace that kind of wears out over time, where you get some fraying of certain fibers, but certain fibers still attach. And what can happen is, as the cuff tendon starts to wear out, you rupture of certain fibers, so a partial detachment, but a portion of the tendon will remain attached. And some you can just have detachment of fibers with just a bit of fraying at the tendon edge. Others you can have almost essentially complete with just a few frayed fibers attached and keeping the tendon in place. So you kind of a wide range of degree of partial tears. And then of course we have full tears, which are complete detachment of the tendon away from bone. And this we really like to focus on what we're really trying to treat with surgery. When this tendon detaches from the bone, we'll see in the next slides, really that's what kind of happens. That's what kind of starts the downstream effects that can really adversely alter the muscles and the tendons of the rotator cuff, as we'll see. But a full thickness tear is a complete detachment, and the tendon gets off away from the bone, and it starts to, because of the pull of the muscle, retract away from where it's supposed to be normally attached. We can see this arthroscopically when we're looking inside the shoulder and looking down on the tendon. Here's a big hole here. Here's the edge of the tendon, and this is supposed to be attached over here. Progression is something that we're becoming more and more attuned to. And what happens, what we think happens is, remember we talked about that spectrum of disease progressing from just a little tendinitis to full tears, and we think that's in general what happens over time. If we look at the rotator cuff, this is the front, this is the back, and here's the outside. And through this, the way it usually starts is a little bit of tendon wear and tear and irritation in the front, and this can progress to some fibers rupturing and some tearing developing. Time can progress to full tearing. Now what happens is this tendon edge detaches away from the bone. You can see from the muscle here, and so the muscle is continually pulling this tendon edge away from where it needs to be attached, and that's an important point. Come back to towards the end. That's the reason why these thickness tears don't heal. There's no evidence that full thickness rotator cuff tendon tears will heal, because there's nothing that's going to counteract the force of this muscle pulling it away where it needs to attach. And in fact, they tend to enlarge over time. And this can become a problem where if enough of the tendon's involved, you lose that containment function of the rotator cuff. And then you have a big problem in terms of loss of the regular biomechanics of your arm. And occasionally people can lose the ability to raise their arm. So tearing, well, even just a little bit of tearing can disrupt the mechanics of the joint, and this can lead to inflammation, particularly in the tendon and bursa surrounding it. This causes pain, which can limit motion. You have poor joint function. A lot of patients will complain of some painful popping and clicking. And what we're really recognizing is that muscle detaches, moves further away. As the tendon is not detached to the bone, or to the bone, the problem is that the muscle that's attached to it is not doing its normal work. And the muscles in our body are kind of designed to do their normal physiologic work. When they don't, we get things like scarring in the muscle or this fatty infiltration. We get atrophy or shrinkage of the muscle, and we get associated stiffening of the tendon as well as the muscle. And what is that these changes may not be reversible. This is an example of what we talk about, that muscle scarring. These are two shots. And what we normally is a nice kind of confluent. This is a muscle belly. This is the top muscle belly of the rotator cuff, as we can see it on the MRI. You can see it's nice and large. It fills this bony space here, and it's very homogeneous, meaning it's the same color and symmetric. And if we look over here, this is one that's had this is a muscle belly. The tendon is torn, and you can see that interspersed in here, these splotches are where normal muscle has been replaced by fatty tissue. Here's a shot showing that muscle shrinkage or atrophy. You can see this nice, broad, very healthy appearing, very confident and symmetric space. And you can see where someone's had a chronic tear. Here's that same bony space down to a pea size. That these on the muscle belly are reversible, and as you can see, they can negatively affect long-term shoulder function over time. Even if you go on to have a tendon repair, the point is that the motor's kind of shot, so to speak. And even if we can get the tendon to heal when there's been these muscle changes, people will still have pain, weakness, and dysfunction changes in the muscle. So that's really just what's rationale for surgical treatment. Again, there's no evidence that these full thickness on their own, they tend to progress and get bigger over time, as we saw. And what we're trying to do is prevent those irreversible muscle changes that can occur with full thickness tears. We're seeing now that we're offering early surgical intervention for painful full thickness tears. Remember, only talking about tears that are causing symptoms. And we're recognizing that when we do rotator cuff surgery, if we're fixing smaller tears, we have better healing rates and better outcomes. So it's better to get to these earlier. You definitely have a better chance of being a home run with these. Go to alleviate pain. Again, we want to intervene before any of those changes in the muscle come about. And we think this is the best way to maximize our long-term shoulder function. Surgery, getting to the actual surgery itself. Well, day surgery, it's done on an outpatient basis, which means you come in the morning and generally leave early in the afternoon. You go the same day. It's done under a nerve block anesthesia, which we'll go through. It's an arthroscopic procedure. I would say for probably about 90 to 95% of these, it's done arthroscopically through small incisions. So it's done in a minimally invasive manner. And then following this, there's a stage therapy or rehab protocol, which is very specific, that follows a certain timeline, and then for 6 months after surgery. It's important to remember that people regain strength and motion and make improvements in rotator in rehab for 12 to 18 months after surgery. So it's a pronged process. This is just an idea of what the nerve block anesthesia is. What the anesthesiologist will do in the holding area before surgery is use an ultrasound probe, which you see here, a small area in the base and the neck. And about this is the ultrasound probe allows them to place the needle with some numbing medicine right adjacent to the nerve roots coming off the spine, which you see down in here, that innervate shoulder area. And this white line is the needle that's going in, and they can see this very precisely placed right next to the nerve roots and numb the area around these nerve roots, which does two things. It gives us great anesthesia for during the surgery. We'll give you some sedation, so people generally fall asleep, but you don't require general anesthesia for this procedure, so it's very safe in that regard. And all this nerve block or this numbing medicine in these nerve roots will last for several hours after the surgery, so it's good for pain control after the surgery. There's a couple different ways to do this. I prefer this beach chair position where the patient's sitting up like you see right here. Pointers out. I think this is a little bit more natural and anatomic to perform it in this position. There's ways that it can be done with the patient lying on their side, and that's commonly performed. Here's what it looks like when the patient out and expose their shoulder before the surgery. There's a special arm holder that we use, so we're kind of hands-free. We can position the arm anywhere we want to in space, and that get to all parts of the shoulder that we need to see. Again, that's done in a minimally invasive manner through very small incisions, all in kind of underneath the shoulder blade. So here's the shoulder blade that's kind of outlined. Here's the collarbone. And you see where we place these incisions. We're just rotator cuff space just underneath that that acromion or the roof part of the shoulder blade. In this picture you see here, we're able to slip instruments in there and clearly gain access to the rotator cuff. Here's a relatively large tear with a free tendon edge here that needs to be attached back here. This also, performing the procedure arthroscopically, also allows us to kind of look at the shoulder joint in its entirety. We get a good view inside the joint around the rotator cuff space, and this allows us to address coexistent pathology. Seen a doctor for rotator cuff problems may have talked with them about the fact that there's some irritation or some tendonitis in the biceps tendon, or possibly a loose body in the shoulder, or maybe some arthritis in the AC joint that need to be addressed to the rotator cuff problem. This is done very easily arthroscopically. We can see those all those structured shoulder. And when we talk about bone spurs, what we're talking about is removing excess bone from this roof bone. And this is a picture courtesy of our friends in Germany, the German literature, but I think it shows this very nicely. This is looking from the side. Here's the roof bone here. This is the rotator cuff space. The rotator cuff's not pictured here, but this is where the rotator cuff normally would lie. And you have people develop bone spurring at the top, and so this roof bone, that can really impinge upon and encroach upon the space available for the rotator cuff. So part of this procedure, if someone does have a lot of curve to the acromion or some quote-unquote bone spurs in this area, we use shaving device to kind of debride and smooth that down. When we look at it in surgery, you can see these very clearly. When we remove the soft tissue from the top and front part of the acromion, you can see this big spur that kind of digs down in here. When we do our rotator cuff repair, we don't want this thing digging right in there, so we can smooth that out and create a lot of space for the cuff to move freely there. That's the subacromial decompression. The next step is to kind of get a sense of how large the tear is, debris, the inflammatory tissue that's around it. And we can see quite clearly here, here's the tendon edge. We're removing just soft tissue from around the tendon edge, trying to get an idea of what we're actually looking at, and we're going to go about repairing this. Each of these are a little bit different. They're used to help clean any remaining soft tissue. Sometimes there's little remnants of tendon that are attached to the bone where it's ruptured off the bone, and we want to clean that up and create a nice bony bed that will ultimately repair this tendon edge back to. And then look at the tendons. We kind of grab it in various positions, and we kind of plan out exactly where we want to put our suture anchors and how we're going to tie this down so it's as anatomic as possible. And you can see this very clearly with the camera, the arthroscope, and with these instruments that allows us to do this. So greatly in doing these arthroscopic repairs is these suture anchors. And what they are, you can think of them as kind of like little tiny screws that we put into the bone, and the stitches that are attached to them that come out. And this is a picture here in the OR of one of these anchors going into the bone. And once the anchor is fixed into the bone, we can use those sutures to kind of shuttle them through the tendon edge and tie that back down. That's how we fix these tendons back. Grasping and suture passing instruments that we use to pass the stitch through the tendon edge. This is one that I like. It's called the Scorpion. It has these jaws here with a needle that comes up through them after you grasp the tendon edge, and that will pass your suture up through the tendon, like we see here. Excuse me. And the reason why I like this is it gives you a chance to really grab and hold onto the tendon. You can place your sutures very precisely using this method. Once we do that, we have a row of anchors and a row of sutures that we've passed up through the tendon. Then I am down. This is a special device that we can tie knots down through special tubes, or what we call cannulas. That'll just to pass the knot down into the shoulder, and we secure these sutures in place. And what that starts to do is reattach and hold that tendon edge to bone. Let's see this. Here's the tendon, and we've put a row of suture anchors on the inner margin of where we want to repair this tendon to. We've passed the sutures up the margin of the tendon, and now you can see this indentation. We start to secure that down. What we look for is a double row repair, and I'm going to show you that here. This is what we do most of the time. We're only limited if standing and we're the tendon back to its full native point. In cases we're able to do this double row repair where we set up, like we saw before. Here's that in the inner part of the tendon edge. And what we'll do is take a few of those sutures, bring another set of anchors that's sitting out a left side, and if we secure those down, it creates this kind of knitting effect that you see here, that edge of the tendon, and we call this a double row or a suture bridge repair. And what it does, and I should put in this little schematic here, it just creates 4 points of fixation, netting in between that really holds that whole the tendon back to where it needs to be to heal properly and anatomically. And we find this is our best healing rates when we do this way, and that's what we shoot for. After rotator cuff repair. This is a big topic. I would say that we do the surgery, and it's nice to see how the technical aspects of the surgery are done, but the rehab after rotator cuff repair is at least as important after the surgery. The reason this is the surgery just places the tendon where it needs to heal and holds it there. What needs then is the tissue needs to heal properly before the tendon can become fully functional. And so this obviously takes a period of time. There's a bit of protection that you need to go through after the surgery to allow the tendon to start to heal. And it starts slowly healing, progressively loading the tendon within safe parameters and safe restrictions to fully functionally. The reason why I put these histology slides in here is the rehab protocol that we use is based upon what the time frame is for microscopic healing of these tendon fibers to bone. And this has been looked at very extensively. This is a normal of a rotator cuff tendon. Here's the tendinous part. Here's the bone, and you can see that the fibers of the tendon attach right into the bone here. That's what we're shooting for. This is a healing rotator cuff. This is an animal study where they've done a thing of this and looking at it under the microscope at a certain time point. And you can see, based on the staining here, that this has just started to heal in a certain portion of this, but still has a way to go in other places. And so we kind of use this information, what we know from these animal studies, to devise how we structure our rehab protocol and how we can put the tendon at different time points. And remember that based on the animal studies, it's approximately 26 weeks. This is 6.5 months for the strength and maximal healing of the tendon. So it takes a while for this thing to really fully heal. It's not as though you're non-functional for an entire 6.5 months after surgery, but this is important to keep in mind that the tendon needs to be protected a long period after surgery to really get best outcome. This overview is kind of a busy slide, but just to give you an overview of what we do, we kind of divide this into 6 weeks periods, the being kind of a protection and early motion phase, the next being just an active motion phase where you're just starting to lift the weight of the arm against gravity, then early strengthening, and only at 4.5 months and on, you go to advanced strengthening with important caveat that, like I said, it's really 6 months before the shoulder is able to withstand any kind of heavy labor or on it. For the week or so, we just recommend rest. We put people in a cold therapy unit. That's what you see here. Patients love this. This is a little pad that attaches to the shoulder and attaches to And what it does is it just circulates cold water continuously through this patch, so it's very good to help in inflammation and keep you comfortable after the surgery. You're also going to be, patients are also in this abduction pillow or an abduction sling or a special pillow sling that holds their arms slightly away from the edge of their body, and this increases tension where we do the repair. It's important where you're going to be in the sling for 6 weeks after surgery as the tendon just starts to heal up. And we see people about 7 to 10 days after surgery. We remove the sutures. We go through the pictures from the surgery, and then I do some home exercises that they do just on their own, just simple stuff for the first 6 weeks. 6 weeks period, it's a progressive, or it's a protection period. The tendon to heal, so we can't put too much stress on it. Again, you're in the sling for this to allow the tendon to heal up, but we also do some gentle motion exercises. These are light, what we call pendulum exercises, where the arm's just kind of dangling with gravity, and this just kind of gets a little motion into the shoulder without stressing the tendon too much. And then at about 4 weeks, the tendon's healed enough that I can add some light rotation exercises just by having the patient hold, say, a stick or an umbrella or a putter between both hands, and the affected shoulder been operated on and kind of go along for the ride while the opposite shoulder pushes the sling to kind of rotate it out. And that's 6 weeks. After 6 weeks, the tendon's healed up enough that we can start actively moving the shoulder. You're stiff at that point. You're a little bit weak and deconditioned because you've been in the sling for 6 weeks. So we start you off with some exercises, which uses the good shoulder to help the operative shoulder start being elevated. You can also do this with a stick, and you can also do this by just simply kind of putting your hand against the wall and kind of using your fingers to kind of climb up the wall. And I'll just get the shoulder used to moving and getting back into these positions. And this is really all you do for the next 12 weeks, with the being that you know, full range of motion at 12 weeks after surgery. This is the touchdown sign. It's important to remember that this is a guideline. This I'd like to see. Some people go a little bit quicker than this. Some people go a little bit slower. Everybody's a little bit different. But at 12 weeks now, the tendon's healed enough that we can just start at this point loading it with some strengthening exercises. And we're really strengthening at 12 weeks. We do this with these what are called therapeutic bands or elastic bands. Different colors have different resistances, and the therapist can kind of guide you through this. Start doing light exercises, raising out in front of our body, out to the side, and then these rotation exercises. And all of these are designed to kind of strengthen all phases of the rotator cuff in a very gentle manner. What we work on is very light tension, very high repetition, trying to build muscle endurance. And then at 4 weeks, we progress into more advanced strengthening and functional rehab. These are more kind of complex movements, these kind of complex karate motions, rotation, overhead motions, and working on things that, you know, there are certain sports or fun things that people have to do at this period. We tailor the rehab to that. And that takes us to about 6 months, where really at that point we say people are kind of okay to go back into their activity, okay to can start throwing fastballs. But you'll be in the surgery for 12 to 18 months and even longer after surgery. And so what we generally prescribe is people go on a maintenance program just at home on their own, regular exercises 3 or 4 times a week. And the 5 cardinal exercises for the rotator cuff. If you'll notice, all below shoulder level. So we don't want to do anything above shoulder level that's going to stress the tendon too much. And there's also not a lot of strengthening exercises with the arm going back behind the plane of the body. We don't really want to put it in that position either. It's just simple, straightforward raises to the front of the body, to the side of the body. This is the front part of the deltoid, as well as the supraspinatus, or the top rotator cuff tendon. These rotation exercises where you're rotating the hand out away from the stomach, as well as rotating it in on this resistance band. There's ways to do this with a dumbbell lying on your side. This gets the back part of the rotator cuff as well as the front part of the rotator cuff. And then finally, these rowing exercises, which gets the back part of the deltoid as well as the back part of the rotator cuff. And really, with these 5 simple exercises, you can really hit all parts of the rotator cuff and keep it tuned up to maximize your long-term function. And, multiple studies have shown after rotator cuff repair, you can expect 85% good to excellent results in terms of pain control as well as patient satisfaction. In cases where the tears have been long-standing, where those changes have occurred previously, this can definitely affect outcome in terms of strength and function. That's recommending that we get to these tears a little bit sooner when smaller, as the rates, outcome scores from this and the long-term healing rates are generally better for smaller tears as opposed to larger tears, and that's seen and then down here, or if we look at the rate of re-tearing or incomplete healing, small or medium-sized tears, these are on the order of about 1 to 2 centimeter tears, that rate is only about 20%, whereas a long-standing tear with a lot of the muscle it's retracted a long way away from the bone, large surface area, you have up to a 95% rate of incomplete healing in that tear. So how do we maximize outcome? Well, it's remember, and the reason why I say this, a lot of people who undergo rotator cuff repair also either know people or have undergone, say, a hip or a knee replacement. Rotator cuff repair is a completely different operation. It's not the same as a joint replacement. The rehab for it is a lot longer, and you got to be a lot more careful with it. That is we're trying to get the tendon to heal in a rotator cuff repair, whereas joint replacement, we either cement in the components or we press fit the components in so they're stable right away. So that generally means people are allowed to do stuff more quickly than they were when you're trying to get something to heal. So it's important to remember that. It's important to identify these tears early. We're on early surgical intervention here, again, for these full-thickness tears. We think that maximizes outcome. Important to adhere to the post-op precautions and restrictions. And the rehab timeline corresponds to the healing time, so there's no shortcuts here. We just have to allow the tendon to heal and progressively do the exercises as we maximize our outcome. And I always say this at the end of a rotator cuff lecture, be good to your rotator cuff. It's the only one you got, and you want it to function well for you for a long time. Thanks for listening.
Extremely informative presentation. For more information on Dr. Boes or Raleigh Orthopaedic Clinic, please visit www.raleighortho.com, or you can visit Dr. Boes' website at www.md.com. Thanks so much and have a good day.